Oh, thanks very much, Dr. Chow, and to the AIM at Melanoma Foundation. This is a real pleasure. Greatly appreciate it. Today I'm going to be talking about just the basics of radiation, as well as when we sometimes use radiation therapy for patients who have melanoma. I want to back up a bit because we often think of radiation as something to be avoided. Certainly in contemporary culture, gets a lot of headlines, news articles. In fact, there's been studies of just the New York Times looking at radiation therapy and whether these are positive or negative stories over time. And over the past 20, 30 years, the trend has been more and more negativity. And so why on earth do we still talk about radiation therapy? What is it? How is it used in cancer? And what's its role nowadays? And so I usually start from just a very basic explanation of what radiation is. So we're usually talking about photon radiation. These are X-rays in the electromagnetic spectrum. And X-rays interact with matter. They interact with the body. They interact with cancer and tumors and other parts of the body as well. The way that they do that are multiple different ways. There are multiple different effects that have been well characterized for the past 100 years. Some of the most famous and most important in radiation are the photoelectric effect, where a X-ray will come in, interact with an electron of an atom, and that electron will absorb that energy and be expelled. Or the Compton effect, Compton scatter, where the photon is slowed down and also kicks off an electron. So the photoelectric effect is the effect that was discovered or characterized by Albert Einstein, leading to his Nobel Prize, so not general relativity. And so these are important characteristics that have been well described for the past 100 years. We know that with higher energies or more intense radiation therapy, we can deposit energy further into the body. So these are just the depth into the tissue that energy is deposited with radiation. And it has an additive effect. So if we use radiation beams from multiple different areas, that effect is cumulative. So we can use that property to carefully carve radiation around different parts of the body, around different tumors. Inside the body, radiation interacts with DNA. That is a therapeutic benefit to it. The way that it does that is it kicks off electrons that interact with water, creating reactive oxygen species. These are typically the species that interact with DNA, causing DNA damage. There are other less common ways that radiation can interact with DNA, but that's the most common. Cumulative effect of DNA damage results in cells dying. So tumor cells tend to reproduce rapidly. And in doing so, that DNA damage that they have results in cell death. We have a less intuitive sense about how radiation therapy works compared to a systemic therapy, a chemotherapy, a pill medication, or even then surgery. I think we have a really natural, intuitive sense about how all of those things work. Usually, we have less of a sense of how radiation therapy works. So after we meet patients in clinic, in radiation oncology clinic, we discuss the benefit of radiation. And if we decide to pursue radiation therapy for those patients, we'll move forward with a plan. We do what's called a simulation, which is also known as a planning session. These simulations are typically involve a CT scan that is special for the radiation oncology department, different from those you might otherwise get through a diagnostic radiologist. We use that simulation to create a radiation plan, which can take a number of days, a week, or even 2 weeks before we start radiation delivery. During delivery, we usually break up radiation treatment into multiple days that can last days or weeks. And throughout that time, we will meet patients, discuss any symptoms they are having, any side effects that they're having from radiation treatment. So in that planning session, what happens during simulation? I mentioned a CT scan. It is unique and different from other CT scans because patients are in a treatment position. So in radiation oncology, we really treat from head to toe, top, bottom. And so we have to expose the area of the body that we want to treat with radiation. So if it's in the brain or head and neck, it's usually arms down. We may often make masks that hold patients perfectly still because it's very important to be in exactly the same position from planning session to every day of treatment. If it's in the chest and the abdomen, we might have patients with their arms up and create a mold to hold them perfectly still. A lot of departments use tattoos on patients. It's something that people are really familiar with, and I'll show you what that kind of looks like as well. This is what our simulation room looks like downstairs here at the Chow Irvine Center. So this is a CT scanner on the bottom left. And then backing up, this is what the console looks like in the workroom. This is what our lead therapist here at Irvine. And this is just an example of what it looks like to have your arms up and the type of body mold that's created. This is an example of like what a small tattoo looks like. So these are used as markers for where radiation plans should go to. We use these to help make the process quicker treatment. We don't use these so much anymore, but people are very familiar with what they are and what they look like. And it's just for marking purposes. So we saw a picture already, but here's two pictures of the linear accelerators downstairs at Chow. So this is one of the therapists at Irvine. And this is a linear accelerator. These are machines that weigh thousands of pounds, and they rotate on a chained gantry with millimeter precision. There is a table, we call it couch, that moves in and out and rotates around. So many degrees of freedom of motion for patients to move around and for the linear accelerator to move around. Getting into melanoma and why we use radiation for melanoma. It's not often used for patients who have melanoma that is not metastatic, that have early stage or curable melanoma. When it is done, it is often an adjunct to surgery. We call this adjuvant therapy when it is done with surgery. Typically, it would be after surgery. In those cases, it is a preventative measure. So surgery has occurred, the tumor has been removed. We use that radiation therapy to prevent it from coming back in that location. A couple of the indications for when we do use radiation for cutaneous melanoma after surgery. If the margin was positive and there is no option to do more surgery, we will recommend radiation therapy to that site. There's another uncommon type of cutaneous melanoma that tends to spread along the nerves. These are teeny tiny nerves that are not easily visible, but are visible under a microscope. This neurotropism, the ability or the tendency to move along the nerve sheaths. And there's a certain subtype called desmoplastic that tends to do this, is defined by this, in fact. When we do radiation for a cutaneous lesion of the skin, two very common regimens to perform the radiation are 5 treatment sessions or 20 treatment sessions. So this will last 2 to 4 weeks of daily treatment. This is that uncommon type of melanoma, desmoplastic. It's been well studied. It is uncommon, so it's hard to do clinical trials for this subtype of skin melanoma. But retrospective studies have been done. And for example, all comers of this type of melanoma, the chance that the tumor recurs in the same location, 24% when radiation is not given, 5% when it is given. There seems to be a real benefit. That benefit is even more dramatic when looking at whether or not there are positive margins after surgery, or specific tumors that have perineural spread, the other indication. Another uncommon subtype of cutaneous melanoma are those that have a propensity to spread to lymph nodes of the body rather than throughout the rest of the body. So lymph node spread has been tested in a clinical trial from the Tasmanian group TROG. They looked at patients who had skin melanomas that spread to lymph nodes and thereafter were treated with or without radiation therapy. So very basic question of whether to do radiation or not. There was a benefit to doing radiation in terms of the tumor recurring in the lymph node region. so 36 versus 21%. Notably, these studies are difficult to do, are not repeated often. So this study started in the early 2000s. It predated the use of immunotherapy for melanoma in general. It predated the use of immunotherapy for melanoma for resectable disease, where it has spread to the lymph nodes. So we're sort of in an area where the benefits of radiation for these types is not entirely known, and so is not always indicated. Moving to patients who have melanoma that has spread to other parts of the body, we use radiation therapy a lot. That's the dominant form of radiation that we are using for melanoma. When it has metastasized, it often metastasizes to the bones or the spine bones, and radiation can be quite helpful for alleviating symptoms. Most common symptom is pain. So tumors of the bone can be painful. They do cause release of cytokines or inflammatory markers and can stimulate pain receptors. In addition, tumors of the bone destroy the bone, can cause fractures. If you can imagine, a break of your bone is intuitively painful. Same type of pain with tumors of the bone. These radiation courses tend to be shorter. 1 to 10 days is very, very common. These are what these types of radiation plans look like, where there's a cumulative dose throughout the body targeting the bone. This is planned for half of the pelvis that was performed. How well does radiation work for pain? In radiation, we try to be very, very evidence-based. We really try to focus on what literature has shown us, what clinical trials have shown us. There's a wealth of data for the use of radiation for metastatic disease for bone tumors. It works about 2/3 to 3/4 of the time, helping with pain somewhat or entirely. So not everyone has pain remission after radiation therapy, but it is the vast majority of patients. We tend to see that higher doses may be more beneficial. The pain response may last longer. We call this stereotactic body radiation therapy. It's one of the more recent uses and indications of radiation, where you use a very high dose of radiation at a very targeted area, typically a smaller tumor. Brain metastases. I thought Dr. Moyal would bring up Jimmy Carter because he was just in the news. So a very famous case. So President Carter was diagnosed with melanoma in 2015. From news articles, and this is all public information, he was diagnosed after liver biopsy or liver surgery. So at that time, the melanoma had spread to the liver as well as the brain. His first treatment for melanoma was actually radiation. It was brain radiation. And that was followed by Keytruda pembrolizumab immunotherapy. The details of all of his treatment course are not known, but he entered hospice care in February of 2023 and then finally died just a month and a half ago in December. So he survived 8 or 9 years with metastatic melanoma, which is really remarkable given how far it's come over the past decades. So talking more about brain tumors, we often are using radiation therapy because this is a very important structure of the body, and tumors that are even very small can be highly problematic in the brain. Some of the symptoms, nausea, vomiting, headache, or focal neurologic symptoms. These are things akin to having a stroke, weakness, or sensory loss. There are 2 flavors or forms of radiation to the brain. Radiation directed at the entire brain, we call this whole brain radiation, or more focused radiation, brain radiosurgery. These are a couple of the contemporary plans of what brain radiotherapy looks like. It does help reduce and alleviate the symptoms where there are tumors in the brain. The bigger benefit tends to be preventing new tumors of the brain from popping up or establishing. So for people who have brain tumors across all different types of cancer, whole brain radiation can cut down in half the chance that new tumors pop up. With melanoma, it tends to be more resistant to radiation therapy. And so using the low dose that's given to the brain for whole brain radiation is not as effective. And so instead, we use the high dose type of radiation therapy directed at very small tumors. We call this brain radiosurgery. Some of the companies and some of the machines are really well known. You see news articles about them. People will ask about them. Those include Gamma Knife, the CyberKnife, the ZapX machine is a more recent one, or the TrueBeam machine. And all of these deliver the exact same type of radiation that I talked about at the very start of this talk, X-ray radiation. And in fact, the exact same energy of X-ray radiation. So radiosurgery is extremely effective at treating brain tumors. Again, it's been established for decades. The first study of this that really established the doses to use for brain radiosurgery date back to the early 1990s. And in that study, tumors that were small could be killed and controlled and not come back 85% of the time with a single treatment of brain radiosurgery. The field has established and contemporized much since then. For larger tumors greater than 2 centimeters in size, we will often break up the radiation therapy and be able to achieve similar results. For very large or symptomatic tumors, we often find that the best treatment starts with surgical resection, where radiosurgery is an adjunct to the surgery that's been performed. Again, has been well established in clinical trials. This is an example of a radiosurgery plan. So on the bottom right is the cumulative dose that is delivered simultaneously to this patient. Had 11 different tumors spread throughout the brain. And what you are seeing in the videos are the profile of the radiation beam and how it carves around these individual tumors as the linear accelerator moves around the body in different dimensions. And with that, I will end and I think questions at the end. So thank you.